Karim, 3, 2, 1.
Good evening, our dear followers on CEC. Today we are reviewing some clinical trials that were published last year at 2020. This clinical trial carry a lot of information that we can apply in clinical practice. I have the honor to welcome our dear friends, Dr. Omar Saleh, the lecturer of cardiology from Suez Canal University, and Dr. Amir Mustafa, lecturer of cardiology at Cairo University. So now I'll pass the mic to Dr. Omar Saleh to start the discussion of two important trials that were published in 2020, which are LODOCO 2 trial and Alpheus trial. Dr. Omar, please go on.
Thank you very much, Dr. Karim. I have the great honor to be here with you in the CEC channel. Our two trials that, as you mentioned, are trials that are talking about drugs. These drugs maybe have been in use a long time ago and now are used a lot in our clinical practice. Let's start. I'm sorry, I'm just, okay. The two trials, the LODOCO 2 trial and the Alpheus trial. Let's start with the LODOCO 2 trial. And this trial was published in the New England Journal of Medicine and was presented in the European Society of Cardiology 2020. It's about the colchicine in the patients with chronic coronary disease. And as you all know, that inflammation is a very well-known process in the coronary artery disease patients. It's characterized by a lot of inflammatory infiltrates, and these inflammatory infiltrates are responsible for what leading to the plaque formation and the plaque rupture and so on. And this inflammation has been targeted a lot in a lot of trials, like the CANTOS trial, which has been addressed with the canakinumab drug. This is an anti-inflammatory drug that targets inflammation in coronary artery disease, and it was a positive trial. It proved that this anti-inflammatory drug was very effective in preventing long-term cardiovascular outcomes. The colchicine in itself is a well-known drug with anti-inflammatory properties, and it has a broad cellular effects that include the inhibition of the tubulin polymerization and alteration of leukocyte responsiveness. And this drug has been used very long time ago, more than 2,000 years ago, by the ancient Egyptians and by Greeks for curing a lot of diseases. In one of the trials that has addressed the colchicine use, the COLCO trial, it involved the patients with myocardial infarction. And its primary endpoint was lower among those who received 0.5 milligram of colchicine, the low dose of colchicine, once daily, than those who do not receive colchicine. So based on this, the investigators had a trial, the LODOCO 1 trial, and they addressed the patients with chronic coronary syndromes. They administered low dose of colchicine in around 532 patients diagnosed already with chronic coronary syndrome. And this was a positive trial also, so that they, according to this, they planned the LODOCO 2 trial. Its objective was to determine whether the colchicine 0.5 milligram once daily will prevent the cardiovascular events in patients with chronic coronary syndrome. They carried out an investigator-initiated, double-blinded, placebo-controlled, event-driven trial, which started first in Australia, then some centers in Netherlands were added, and this trial ended its enrollment in 2018. Simply, they enrolled patients with 35 to 82 years old and has proven coronary artery disease already with clinical stability within the last 6 months. They run in a 1 month, 30-day open label so as to test the colchicine in those patients, because the colchicine is well known for its side effects. These side effects, which are common, the GIT side effects and muscle side effects, these patients were excluded from this trial, and if they are tolerant for the drug and they are clinically stable and are willing to be enrolled, they were then randomized to receive colchicine or placebo. The inclusion criteria: age around 35 to 82, evidence of coronary artery disease on either invasive coronary angiography or computed tomography. The angiography or coronary calcium score should be more than 400 AEGIS units on a coronary artery calcium scan, and these patients should be clinically stable for more than 6 months, as we said before. They excluded the patients with moderate to severe renal impairment, patients with severe heart failure and severe valvular heart disease, and if they have already known side effects for colchicine. And their primary endpoint was the composite of cardiovascular death, myocardial infarction, ischemic stroke, and ischemia-driven coronary revascularization. The secondary endpoints were either the cardiovascular death, myocardial infarction, or ischemic stroke, or myocardial infarction or ischemia-driven coronary revascularization, or cardiovascular death or myocardial infarction, or ischemia-driven coronary revascularization alone, myocardial infarction, ischemic stroke as individually, and death from any cause or cardiovascular death. They enrolled around 6,000 patients, and from these 6,000 patients, only 91% tolerate the dose of 0.5 milligram of colchicine. So they randomized 5,522 patients, which were followed for a median of 29 months, and the trial closed on 5,521 patients as ended their follow-up in February 2020. First, the results show the baseline characteristics, no significant difference between the two groups. And regarding the primary endpoint, the colchicine was better than placebo with p-value highly significant and 0.69 hazard ratio if we compare the two arms. Regarding the primary endpoint, which was the composite of cardiovascular death, myocardial infarction, ischemic stroke, or ischemia-driven coronary revascularization. The separation of the curves is very early, less than 12 months. As you can see here, there was a big difference between the placebo and the colchicine patients. Regarding the key secondary endpoint, which was the cardiovascular death, the myocardial infarction, or ischemic stroke, also there was significant difference between the two groups regarding this secondary endpoint, and this also was found through all the ranked secondary endpoints except for the ischemic stroke, which was a little bit higher in the placebo group without any significant, any statistical significance. Regarding the serious adverse events, there was no significant difference between the two groups, but as you can see here, the non-cardiovascular death was a little bit was higher in the colchicine group, and they stated that this has no any explanation why the non-cardiovascular death was high in the colchicine group. However, this number does not reach any statistical significance. Also, the patients with receiving colchicine has higher myalgia than those who do not receive colchicine, but this number also doesn't reach statistical significance. So they concluded that in patients receiving colchicine, the LUDOCO-2 provides strong evidence to support repurposing colchicine for routine secondary prevention in patients with chronic coronary disease. To summarize what they found, the colchicine improves cardiovascular outcomes among patients with chronic coronary disease compared with placebo. Reductions were noted in MI and ischemia-driven revascularization. However, there was a signal towards higher non-cardiovascular mortality with colchicine with unclear etiology, as the investigator stated. The discontinuations due to side effects was very frequent with colchicine. However, the dropout from this study were very low, and its results is very significant for our clinical practice. We can jump to the second trial, the ALPHEUS trial.
Thank you, Omar. Let's stop for a few minutes. You summarized the trial very well. I believe it was an important trial, and we have many trials discussing the role of colchicine in management of the patient with coronary artery disease. So what is the added data that LUDOCO trial added to the previous trial, COLCOT and LUDOCO 1?
Okay, the previous trials, as you said, already stated that the colchicine is effective, the Colco trial, colchicine is effective in patients with myocardial infarction. They randomized patients with recent myocardial infarction. And this makes some sense because those patients already had the disease, which is already infarcted, and infarction, at myocardial infarction, as you know, that has a lot of inflammatory reactions and a lot of responses here and there. So it's very plausible to add an anti-inflammatory drug so that you can expect a better results. But in LODOCO 2, they recruited all the patients with chronic coronary syndromes, and this was the target for them. They want to prove that also in those patients who were stable for more than 6 months, even after an event. And as you saw in the figures or in the tables, there are around 80% patients from both groups had already sustained an MI more than 6 months before. And those patients will have been stable and already now in the category of chronic coronary syndrome. So the LODOCO 2 proves that colchicine also is effective in the chronic state of the disease. The LODOCO 1 was a small study. It was a single center study, only on 500 patients, carried on with the same investigators, and just like a pilot study to test the hypothesis that they already hypothesized. But the LODOCO 2 is a more large randomized double-blinded trial, which is better to rely on their results better than relying on the LODOCO 1 trial.
Thank you, Omar, for this explanation. Again, you mentioned the increase in the non-cardiovascular deaths in patient received colchicine, which is not the case in the Colco trial, I think. This is my first comment. Regarding second comment, I think this is an open label trial, which make the power of this trial, maybe it's not so good, and actually this can be taken as a criticism for this trial. What do you think?
Well, regarding the first point you mentioned, they have no explanation for why the patients with colchicine sustained higher non-cardiovascular death. Actually, I have been searching for this, and they mentioned that there is no explanation. There is no specific etiology for non-cardiovascular death, and we cannot rely on this only as a point. I'm waiting for other discussions. I searched for other discussions regarding this point, but there isn't any explanation for why non-cardiovascular death was higher. I don't know really. I didn't find any explanation for this also. Regarding your second point, the LODOCO 2 is a double-blinded trial, but LODOCO 1 was an open label. That's the difference I mentioned earlier. The LODOCO 1 is an open label, single center study, so they cannot rely on its results, on the results already given. So they run in, or they have done another trial, which is the LODOCO 2 trial. The LODOCO 2 trial is double-blinded randomized trial. So I think it's a powerful trial. It's not.
Thank you for correcting me.
Dr. Omar, thank you so much, Dr. Omar. We have a couple of questions from YouTube. Dr. Abdullah Al-Maghrabi from Alexandria is asking you, what were the major side effects noted in the trial for colchicine in the clinical practice in this subset of patients? And Dr. Asma Ghorab is also asking you, according to the results of this trial, would you be enthusiastic to include colchicine in the clinical daily practice for chronic coronary syndrome patients?
Well, thank you, Dr. Muhammad, for these questions. Regarding the first question, the main side effects were the GIT side effects. Patient has gastric irritability. They tried to do a run-in phase for 30 days first before recruiting the patients to test the tolerability for these patients for colchicine, and they excluded already a group of patients who had side effects. So the main side effect were the GIT trouble. The second side effect was myalgia, and myalgia had higher incidence in the patients received colchicine than the placebo. These were the two mentioned more or lead to discontinuation of the drug. Regarding the second question, well, I think, yes, you have to ask yourself this. Will you add colchicine to patients with chronic coronary syndromes or not? Let's first put it in its, point of view. You have to first stabilize your patient from every single aspect. You have to give him all the guidelines recommended treatment. Till now, the colchicine is not in the guidelines, so you will not be asked to add colchicine for every patient with chronic coronary syndrome. I will first give the patient all the drugs that had been already proven and had been already in the guidelines. This is the first thing I have to do. If the patient is still symptomatic, if the patient has high risk features, other high risk features, if the patient cannot be controlled on these drugs, and these patients cannot be revascularized, you have a group of patients, Dr. Muhammad, you know that you cannot revascularize those patients. I feel comfortable to maybe add to colchicine for them. Okay, so it will be also always for me the last resort to add until the guidelines will formulate or will put it in its place. That's it.
So this is actually very nice because this was a new idea to use this medication in this particular subset of patients. Maybe I would like to ask about a second subset of patients. Do we have any data about using colchicine in acute coronary syndrome patients? Because those patients are characterized by a rise in the inflammatory markers and mediators with the ruptured plaque and the initiation of acute coronary syndrome. And this is a strong anti-inflammatory drug. Initially, I think it was prescribed for familial Mediterranean fever, which is one of the systemic diseases characterized by generalized inflammation. So what if this medication has a pleiotropic effect like the statins and can stabilize the plaques in the acute coronary syndrome? Do you believe or do you think that this medication in the next few years will have to be experimented in this field of acute coronary syndrome?
Well, this is a very important point. And it makes sense more than using it in the chronic coronary syndrome patients. We have evidence from the Colchicine trial. The Colchicine trial already tested this drug in the patients with recent myocardial infarction. And it was a positive trial. And it proven that colchicine with a dose of 0.5 milligram once daily, given once daily for those patients already prevent major cardiovascular events. So as it makes sense, yes, this drug was effective in this group of patients. And based on this, the investigators in the LODOCO trial planned this trial that if this drug was effective in the acute coronary syndrome groups, the myocardial infarction group, why not test it in the chronic coronary syndrome group? This was a little bit off-label use. So we have evidence from the Colchicine trial, yes, this group of patients will benefit from using colchicine once daily, 0.5 milligram. That's right.
Thank you so much, Dr. Omar, for this clear collaboration. I will pass the mic to Karim now if he needs to ask any more questions.
Yes, one more question, Omar, because it is a very interesting subject. You know, in the with other uses of colchicine, let's say in gout and the familial Mediterranean fever, it's used in a higher doses than the dose tested in this trial. So what is the rationale behind using a very small dose like 0.5 once daily in a patient with recent myocardial infarction and chronic coronary syndrome, as you mentioned?
Well, this question has been addressed before, and the investigators already used this dose for two reasons. The first reason is, you know that the chronic coronary syndrome patient already has a lot of medications. So that these patients expect to have a lot of side effects and so on. The 0.5 milligram once daily dose of colchicine has not been incriminated in a lot of studies before that it causes side effects like the GIT I said before and so on, because these side effects will lead to discontinuations. So they were enthusiastic to use the low dose of 0.5 milligram once daily to reduce the incidence of side effects and to reduce the discontinuation that may happen from this drug. This is the first point. The second point is that this dose has been tested before. The 0.5 milligram once daily has been tested as effective to prevent major cardiovascular events. So they have a rationale to use the same, dose in their trials, 0.5 milligram once daily, and it gave the same almost or the better results than like the previous trials. That's it.
Thank you, Omar, for explanation, and you can proceed now with the second trial.
Regarding our second trial, the Alpheus trial, this trial has been published in the Lancet recently. Is ticagrelor versus clopidogrel in elective percutaneous coronary intervention. This was a randomized open-label phase 3B trial, and this trial has been presented in the American Heart Association scientific sessions in 2020. So the rationale and the background for this trial that new antiplatelet drugs, the prasugrel and the ticagrelor, provide higher level of platelet inhibition than clopidogrel, with a faster onset of action and better outcome in acute coronary syndrome patients. These two drugs have already been tested, and these two drugs have been used for a long term now in acute coronary syndrome patients because of their unique pharmacological characteristics, and also for a very important point, which is the faster onset of action. However, regarding this, clopidogrel up till now remains the standard of care in elective PCI, as those agents has not been well tested before. The guidelines now, up to this point, gives the prasugrel and ticagrelor class 2B with a level of evidence of C in elective PCI patients. And as you see here, this is from the guidelines or a recent article about the guidelines, that in elective PCI, dual antiplatelet with aspirin and clopidogrel is indicated for 6 months, followed by a single antiplatelet therapy. But the PCI-related myocardial injury or type 4A myocardial infarction is very frequent and may occur to up to 50% in patients with undergoing elective PCI. The atherothrombotic complications, which we all face during our PCI procedures, the side branch occlusion, the flow reduction, or coronary embolization, are the most likely mechanisms of this procedural myocardial injury. It means that you have a subset of patients during your elective PCI may sustain a type 4A myocardial infarction, and this has a maybe asymptomatic. Maybe the patient do not have any ECG changes after a period of time, but it may prolong the hospital stay. You may let your patient stay a little bit longer in the hospital waiting for the outcome after you see this during the procedure. So it's testing the rationale that if you give a higher potent platelet inhibition using a stronger P12 inhibitor, the prasugrel or the ticagrelor, before and after PCI may be a relevant strategy to lower this MI and myocardial injury may be reduced. But however, up till now, this is not supported by any scientific evidence. So the objective of this study is to examine the effect of ticagrelor as compared with clopidogrel to reduce peri-procedural myocardial necrosis in stable coronary artery patients undergoing high-risk elective PCI. And they chosen to go through patients who are high risk already for elective PCI. They designed their trial with around 1,900 troponin negative patients, or may have some modest positive with high sensitive troponin scheduled for PCI. They were randomized to ticagrelor as 180 milligram, or clopidogrel loading dose may be 300 or 600 milligram according to the center. The loading dose, then after this loading dose, the PCI procedure was carried on. They evaluate the troponin post PCI, and their primary endpoint was myocardial infarction type 4 or type 4A or 4B, which is trans thrombosis, or major myocardial injury at 48 hours or discharge. Then these group of patients in an intention to treat analysis were continue on the ticagrelor for 90 milligram twice daily, or clopidogrel at 75 milligram once daily, followed up for 1 month. They included patients who are male, more than 18 years old, or non-pregnant females undergoing non-emergent PCI, having at least one high-risk features of for undergoing PCI, these high-risk features in the right side. As you see, these two squares, the patient-related risk factors, age more than 75, creating clearance less than 60, diabetic or BMI more than 30, or history of acute coronary syndrome in the past 12 months, ejection fraction less than 40, and or prior episode of heart failure. These are patient-related risk factors that they consider high-risk features, or procedure-related high-risk features like multivessel disease, multiple stents needed, left main bifurcation stenting, ACCH A-type B2 or C lesions, venous or arterial coronary graft. These considered as a procedure-related high-risk feature. If the patient has at least one high-risk feature, is considered to be included in this study. Those patients should have negative troponin or moderately positive and decreasing before the PCI. It means that they are not in the active phase of the acute coronary syndrome status. They should provide an informed consent obtained and enrollment in the study. They excluded all the patients with acute coronary syndrome or all the patients who need chronic oral anticoagulation, or if they have other planned coronary vascularization within 30 days. These may be the key exclusion criteria. This is a long list of exclusions, but these were the most important points for exclusion. These patients, exclude this patient. 1910 patients underwent randomization. 956, this is a patient flow chart for this trial. Almost 950 patients were assigned to the ticagrelor group. 950 also were assigned to the clopidogrel group, one-to-one randomization. And finally, 940 patients analyzed in the patient treat analysis and safety population. 940 patients also on the clopidogrel are analyzed for safety. And then the primary endpoint was analyzed at 48 hours, the primary endpoint for the trial. In these 940 patients in both arms, then these group of patients were followed up for almost 30 days. For the results of this trial, the demographics between the two groups was not significant, no significant difference between the two groups. And they stated that the baseline troponin was negative in almost 90% of the patients, which is also was not difference between the two groups. What's important here, you see that almost 94% of the patients in both arms was gone through the radial or ulnar approach. Also, this is an an elective procedure. You don't, they use a lot of the upper arm intervention rather than the femoral, and this reduces the bleeding effects, as we'll see later on. The primary endpoint, there was no significant difference between the two groups. The p-value was not significant. Regarding myocardial infarction solely, the myocardial infarction alone, also there was no significant difference. Regarding stent thrombosis, no significant difference between the two groups, or any major myocardial injuries, no significant difference between the two groups. In the main secondary outcome, there was no significant difference between the two groups. Also, no minor myocardial injury difference between the two groups, or any myocardial injury also was not significant between the two groups. At 30 days, after 30 days, which tested the death, myocardial infarction or stroke, the composite of death, myocardial infarction of stroke or TIA, there was no difference between the two groups also. They tended to be almost one. They seem maybe like similar, or maybe completely similar effect between the two drugs. We're talking about the safety. Well, regarding safety, also there was no significant difference, but at 30 days, as you can see here down here, that ticagrelor tends to have a lot minor bleeding than clopidogrel, and this was statistically significant. When you put this on all major bleedings, it increases any bleeding between the two groups, and the bleeding is in favor for the clopidogrel rather than ticagrelor. And they noted that the dyspnea was the more frequent in the ticagrelor group, around 11.2 as compared to the clopidogrel group. And dyspnea was the most important side effect that lead to discontinuation of the study drug, which is very important for the patient who are undergone stenting. Your patient should be kept on diet, and you have to monitor the dual antiplatelet therapy for this group of patients. You don't want the stent to be thrombosed. So ticagrelor leading to dyspnea, leading to more discontinuation than clopidogrel. It was 2.2% versus 0.4% in the clopidogrel group. So it's already, you have seen that the ticagrelor and the clopidogrel are similar. In another trial, the Sassicaia trial, they tested the prasugrel on almost 781 patients also against the clopidogrel in elective PCI patient. The investigators done a pooled analysis for the two trials together. They put the newer antiplatelet drugs, the prasugrel in this trial, in the Sassicaia trial, and the ticagrelor in the Alpheus trial together, and then test against the clopidogrel. There was no significant difference between the newer antiplatelets and the clopidogrel regarding all the outcomes for the two trials. Even in the bleeding, there was no significant difference between the two groups. So we can conclude that in patients undergoing elective high-risk PCI, treatment with ticagrelor showed no difference compared with clopidogrel in reduction of periprocedural myocardial necrosis. Clopidogrel still has esystrone, is still on top of other drugs, or maybe similar to other drugs used in patients with high-risk PCI. Treatment with ticagrelor did not cause an increase in major bleeding, but increased the rate of minor bleeding at 30 days and dyspnea, and this led to some discontinuation for these patients. The results of the Alpheus trial support the use of clopidogrel till now as the standard of care for elective PCI, in addition to aspirin, and paved the way for the evaluation of other strategies to lower periprocedural myocardial necrosis after elective PCI. The investigators in this study hope that if you give highly effective, potent antiplatelet drugs, you can prevent the periprocedural myocardial necrosis. But however, it comes out as a negative trial. It does not find any difference between the newer generation antiplatelets and the clopidogrel. So they concluded that the clopidogrel is still the standard of care for the elective PCI high-risk patients. Thank you very much.
Thank you so much, Omar. Really clear, and I believe this trial confirms that our practice nowadays is still correct regarding the use of less potent B2Y12 inhibitor, which is a clopidogrel in patients with chronic coronary syndrome. I believe actually the coronary artery disease is divided into two large diseases, which is acute form and the chronic form, and they differ in management, as you mentioned, and still in the everyday practice with elective PCI, clopidogrel is valid and can be used on a routine basis. Thank you so much, Omar. Dr. Zahran, do you have any comment?
Thanks a lot. Yes, I have a question from my own. Maybe this is completes what you said, because you see the data here difference between the Alpheus trial and the Plato trial, because the Plato included the patients with acute coronary syndrome patients, and those patients have a highly activated thrombotic milieu, and for those patients, inhibiting this thrombotic milieu with the most powerful available medication would actually get a reflect on the outcomes of those patients. On the other hand, you have the patients with the chronic coronary syndrome, where they do not have an active thrombotic ongoing event. So maybe in those patients, you do not need to use the powerful grenades for reduction of the thrombotic risk, because this is the usual pattern of atherosclerosis and ischemia. The question is a very smart question from Dr. Abdallah Al-Maghrabi. Actually, he's asking you, Dr. Omar, the design of this trial was a non-inferiority trial, or was it a superiority trial? Because maybe, if they were so confident enough about the ticagrelor, they would design this trial as a superiority trial, and in this case, it would fail. But if it was designed as a non-inferiority trial, then this would be an equivocal result. Do you have any data about this?
Yes. It's a very nice question. Actually, this trial was designed as a superiority trial. They already hypothesized that ticagrelor will be more effective than clopidogrel in preventing myocardial injury during elective PCI. So this came out as a negative trial, as I said in the last slide. So it doesn't prove the hypothesis. Actually, it proves the non-hypothesis that this drug was not was not as effective as they hope it will be effective. You mentioned a very important point, Dr. Muhammad, actually, that the patients who are undergoing primary PCI, for example, or patients with acute coronary syndrome, those patients sustain a highly platelet reactivity. And these patients already will benefit from using the cangalor, for example, using the ticagrelor, using the prasugrel, rather than using the clopidogrel, because in the setting of the acute coronary syndrome, you are waiting for, or you want, a potent and rapidly acting and active form drug that will inhibit the platelets now, rather than waiting for the clopidogrel to work. So it came out very effective in this group of patients. But in elective PCI, in high risk elective PCI, and I insist to mention that they are high risk elective PCI, because you expect some complications during your procedure in high-risk patients, in bifurcations or in dealing with CTO and so. So in this group of patients, there was no difference between the two drugs. So it was a superiority trial testing the hypothesis that ticagrelor may be effective, but it came out negative. It was not as effective as they hoped. That's the point. I answered this question.
They were so confident when they were designing the trial. They had plateau in front of their eyes, and they thought they would get results similar to plateau.
Yes.
That's why. That's why many drugs in certain indications were actually buried alive by this kind of design, because sometimes others say that let's take it in a two-steps approach. The first one would be a non-inferiority, and then the second one would be the superiority. But actually the high expenses of conducting a clinical trial sometimes cannot make you do it twice or in two very similar profiles of patients, one of them to be non-inferiority and the other one to be superiority. Thank you so much, Dr. Omar, for this wonderful...
Dr. Muhammad, it may come into your mind that this trial was not industry driven. Actually, this trial has been sponsored by a grant from the company already, you know, but it came out negative for them, you see?
Yes. The plan was, yes, I know.
Yes.
Thank you so much, Dr. Omar, for this wonderful elaboration and focusing on those two important trials, colchicine in chronic coronary syndrome and ticagrelor versus clopidogrel in chronic stable angina or chronic coronary syndrome patients undergoing elective PCI. I'm very honored and thrilled to announce the next speaker, my dear friend, Dr. Amir Mustafa, lecturer and consultant of cardiology at Cairo University. Dr. Amir will give us a focus also on two of the famous 2020 trials. So please, Dr. Amir, start sharing your screen. If you may unmute your mic.
Good evening, my dear colleagues. Thank you, Dr. Muhammad, for giving me this opportunity. My presentation today will be about important clinical trials in 2020. I'm going to talk about two main trials, which are the RIVER trial and the Explorer hypertrophic cardiomyopathy trial. First, I'm going to talk about the RIVER trial, which is rivaroxaban in patients with atrial fibrillation and a biprosthetic mitral valve. All of us know that when we are thinking about anticoagulation in a patient with atrial fibrillation, we divide the patient mainly into two main groups: patients with valvular atrial fibrillation and patients with non-valvular atrial fibrillation. In fact, the definition of non-valvular atrial fibrillation had changed among the time. First, in 2020, atrial fibrillation, non-valvular atrial fibrillation was defined as atrial fibrillation in the absence of rheumatic mitral valve disease or prosthetic heart valve. This definition was changed in 2006, and they added atrial fibrillation also with mitral valve repair to the definition. In 2014, non-valvular atrial fibrillation was defined as atrial fibrillation in absence of rheumatic mitral stenosis, mechanical or bioprosthetic heart valve, or mitral valve repair. And lastly, In the EHRA 2016 and also adopted by the latest European Society of Cardiology guidelines in 2020, they divided patients with atrial fibrillation and valvular heart disease into two main groups, EHRA type 1 and EHRA type 2. EHRA type 1 included the patient with moderate to severe mitral stenosis or prosthetic mechanical valve. And in these patients, they recommended that warfarin is the oral anticoagulant of choice. No role for the NOACs in these patients. In the EHRA type 2 groups, they included patients with other valvular heart disease with bioprosthetic valves after 3 months post-operative. And in these patients, they give the chance for NOACs to be used as an oral anticoagulant. All of us know that the current practice guidelines for the use of NOACs in patients with atrial fibrillation regarding the patients with bioprosthetic valves recommended that NOACs can be used, but with two main conditions. The first one is that we can use NOACs after 3 months post-operatively. No role for using NOACs in the first 3 months post-operative. The second one is that we can use NOACs if the bioprosthetic valve is in the aortic position or in the mitral position on top of degenerative mitral regurgitation, but don't use NOACs if the bioprosthetic valve is on top of rheumatic mitral stenosis. So what about the clinical evidence behind these recommendations? The European Society of Cardiology guidelines in 2020 recommended that NOACs are contraindicated in patients with prosthetic mechanical valves, and they gave it a level of evidence B, as it was based on some trials, as the Realign trial, in which the bigatran was studied against warfarin in mechanical prosthetic valves, as this trial was stopped prematurely due to increased thromboembolic and bleeding events in the bigatran arm. The other recommendation was the use of NOACs in patients with atrial fibrillation and moderate to severe mitral stenosis. It was not recommended by the latest guidelines with a level of evidence C, as it is only based on expert opinion. There are no clinical trials yet to support this recommendation. Regarding patients with surgical or transcatheter implantation of bioprosthetic valves, no clinical trials up till now. So here came the RIVER trial. The RIVER trial aimed to assess the safety and efficacy of rivaroxaban compared to warfarin in patients with bioprosthetic mitral valve and evidence of atrial fibrillation or atrial flutter. The trial included 1,005 patients. To be eligible for participating in this trial, the patients were at least 18 years of age with atrial fibrillation or atrial flutter, with a bioprosthetic mitral valve receiving oral anticoagulation, and after 48 hours of doing the mitral valve surgery. Patients were excluded from the trial if they had contraindication to rivaroxaban or warfarin, if they had extreme high risk for bleeding, transient post-operative atrial fibrillation, or, of course, mechanical valves. The 1,005 patients were divided into two main groups. The rivaroxaban group, they received 20 milligrams rivaroxaban or 15 milligram rivaroxaban daily if the creatinine clearance was between 30 to 49, and the other group received warfarin with a target INR between 2 to 3. The duration of follow-up was around 1 year. The mean age of the patients was around 59 years. Females represented 60% of the patients. The mean SHAD-VASc score was around 2.6. The mean has-split score was around 1.6. Regarding the interval between doing the mitral valve surgery and randomization, 18% of the patients included in this trial had the mitral valve surgery within less than 3 months. 16% had them between 3 months to 1 year. 30% had the mitral valve surgery within 1 to 5 years, and 30% was more than 5 years. Regarding the results, the RIVER trial showed that rivaroxaban was non-inferior to warfarin regarding the primary outcome, which included the mean time to death and major cardiovascular events and major bleeding. Regarding the secondary outcomes, rivaroxaban was associated with significantly lower incidence of cardiovascular mortality, thromboembolic events, stroke, and bleeding. Regarding valve thrombosis, there was no significant difference between the two groups. So, in this trial, they concluded that in patients with atrial fibrillation or atrial flutter and a bioprosthetic mitral valve, rivaroxaban was non-inferior to warfarin with respect to the mean time until the primary outcome of this major cardiovascular events or major bleeding at 12 months. Of course, this study has some limitations, including that it is an open label design, and also an important limitation is that it wasn't clear if the mitral valve surgery was done on top of rheumatic heart disease, in particular mitral stenosis, in whom warfarin is still recommended as the gold standard oral anticoagulant of choice. So to sum up, the RIVER trial is one of the first trials to directly evaluate the use of NOACs in patients of atrial flutter and atrial fibrillation and a biprosthetic mitral valve. The RIVER trial can pave the road for other clinical trials to assess the safety and the efficacy of NOACs in this patient group, in whom warfarin is still the gold standard as an oral anticoagulant. Okay. So back to Dr. Muhammad for comments.
Dr. Amir. Thanks a lot, Dr. Amir, for this wonderful presentation. And what I really got from this trial is a clear message that we will start investigating the NOACs in this long line of patients that have replaced their mitral valve. And let me tell you that the standard of care for replacing the mitral valve in the Western community is a little bit higher to use the biprosthetic valves than we use them in Egypt, because actually the cost is not a big issue there. So they prefer to use the bioprosthetic valves. And if you are speaking about the issue of degeneration of the valve, now this issue can be easily solved by a transcatheter replacement of the mitral valve using even the TAVI valves. So it's not a big deal actually. So they go against using warfarin because warfarin has lots of bleeding complications, and it's a little bit difficult to follow up the bleeding in those patients and to ensure that the patient is controlled with an adequate INR most of the time. So this is a very smart trial, and maybe I will ask you a simple, easy question to explain to our viewers what was the main difference between this trial and the famous dabigatran trial, which was a big failure in the realign, because actually dabigatran also, they went to use it in mechanical valves, and they were surprised by the incidence of very high rates of thrombosis and at the same time very high rates of bleeding, and this led the investigators actually to stop the trial prematurely. What's the main difference between RIVER and realign?
Thank you, Dr. Muhammad, for this question. I think that as you said, the main difference between the two trials was that in the realign trial, they were studying the NOACs, the dabigatran versus warfarin in patients with a mechanical prosthesis. While here we are studying in the RIVER trial, we are studying the rivaroxaban versus warfarin in a bioprosthesis. All of us know that the risk of thromboembolization in the mechanical prosthesis is much higher than in the bioprosthesis. And that's why this can explain the great failure that happened in the realign trial, as mechanical using the NOACs in the mechanical prosthesis with a very high incidence of thromboembolization carried the risk of increased incidence of thromboembolic and also of bleeding complications. While in this trial, we are using the rivaroxaban versus warfarin in patients with bioprosthesis. We know that the bioprostheses are less thrombogenic, and that if you are talking about a patient, if you are considering doing valve replacement to a patient with high risk of bleeding, and we are going to give low incidence of or short term of warfarin or something, we choose the bioprosthesis rather than the mechanical prosthesis to avoid the anticoagulation. I think this is the main difference between the two studies.
Yes, that's right, Dr. Amir. But when we look at the RIVER trial, it looks like a trial actually investigating atrial fibrillation, because if you are having a patient with sinus rhythm and put a biological bioprosthetic valve in the mitral position, and he is sinus rhythm, he does not have an indication for anticoagulation. What is the routine anticoagulation protocol for a patient that put a bioprosthesis in the mitral valve and he or she is in a sinus rhythm? What is the routine anticoagulation protocol for those patients? Do they need actually anticoagulation or only antiplatelets?
Well, the guidelines recommend that if the patient is having a bioprosthetic valve and he is in sinus rhythm, we can use oral anticoagulation for around 3 months only post-operative, and then anticoagulation can be stopped and the patient continue without anticoagulation. But of course, as you said, in this trial, the main concern is the atrial fibrillation in the presence of the bioprosthetic valve.
Yes, that's right. So, as you said, it's like warming up the track for the upcoming trials in this field of patients. Thank you so much,
Yes.
Dr. Amir. We are interested to hear about the second trial also.
Okay. The second trial that I'm going to talk about today is the Explorer Hypertrophic Cardiomyopathy trial, which is the efficacy and safety of mavasamtine in adults with symptomatic obstructive hypertrophic cardiomyopathy. All of us know that hypertrophic cardiomyopathy is a disease characterized by left ventricular hypertrophy. It is diagnosed by the presence of left ventricular wall thickness in the end diastole of greater than or equal to 15 millimeters or greater than or equal to 13 millimeters if the patient is having a family history of hypertrophic cardiomyopathy detected at any site in the left ventricle and in absence of identifiable cause. It is estimated that hypertrophic cardiomyopathy affects about 1 for every 500 people, and that it is the most common heritable form of cardiomyopathy. Among patients with hypertrophic cardiomyopathy, 2/3 of the patients have the obstructive type, and this obstruction is mainly due to the combination of the left ventricular wall thickness, increase in the left ventricular wall thickness, in addition to the mitral valve abnormalities, which result in dynamic obstruction of the left ventricular outflow tract. Our current treatment for patients with hypertrophic obstructive cardiomyopathy is mainly targeting symptomatic treatment, including medications like beta blockers, calcium channel blockers, and disopyramide, and also interventions which include the septal reducing interventions. But up till now, there are no medications which are targeting the underlying cause of the disease. So, developing effective pharmacological therapy for patients with hypertrophic obstructive cardiomyopathy is indeed an important unmet need. Mavasamtine is a small molecule modulator of the beta cardiac myosin. Mavasamtine inhibits the cardiac myosin, and so it reduces the excessive actin and myosin cross-bridge formation, which leads to the hypercontractility, the left ventricular hypertrophy, and the impaired cardiac relaxation detected in patients with hypertrophic obstructive cardiomyopathy. Mavasamtine was studied in a phase 2 study, which was called the Pioneer Hypertrophic Cardiomyopathy Study, and it showed significant improvement in the post-exercise left ventricular outflow tract gradient and in the NIHA class of the patient. So, regarding the study design, Explorer Hypertrophic Cardiomyopathy was a phase 3 multicenter randomized double-blind placebo-controlled trial, which was designed to assess the efficacy and safety of mavasamtine in adults with symptomatic obstructive hypertrophic cardiomyopathy. Patients were eligible to participate in the study if they were having the diagnosis of hypertrophic cardiomyopathy, as we said before. Also, if they were having a left ventricular outflow tract gradient of at least 50 millimeter mercury at rest or with Valsalva or exercise, if they were having the left ventricular ejection fraction at least 55% with a NIHA class of 2 to 3 of symptoms, and the patient should safely perform the upright cardiopulmonary exercise test. Patients were excluded from the study if they had history of syncope or sustained ventricular tachycardia with exercise in the past 6 months before enrollment. Also, if they had QT interval greater than 500 milliseconds, paroxysmal or intermittent atrial fibrillation, persistent atrial fibrillation not controlled or not on oral anticoagulation. The study included 251 patients in 68 sites in 13 countries. Patients were divided into 2 main groups. Group 1, who received the mavasamtine, they included 123 patients. Mavasamtine was given with a starting dose of 2.5 milligrams daily, and it was up-titrated to doses 5, 10, and also to 15 milligrams per day. The target was to achieve 2 important points. First, reduction of the LVOT gradient to less than 30 millimeter mercury, and also to reach a plasma concentration of mavasamtine between 350 to 700 nanogram per milliliter. And the second group, of course, received the placebo group, and it included 128 patients. Patients were followed up every 2 or 4 weeks for 30 weeks, and follow-up included resting echocardiography, ECG, and measurement of the mavastatin plasma concentration. Also, cardiopulmonary exercise test and post-exercise echo were done at screening and at 30 weeks. Patients were allowed to continue their medications as beta blockers and calcium channel blockers, but not to continue disopyramide due to side effects. The primary endpoint of the study was assessed at 30 weeks, and it included either improvement of the NIHA class of the patients by 1 grade, in addition to improvement in the peak oxygen consumption by at least 1.5 milliliter per kilogram per minute, or improvement or no worsening in the NIHA class of the patient, plus improvement in the peak oxygen consumption by at least 3 milliliter per kilogram per minute. Well, regarding the secondary endpoints of the study, it included improvement in the peak oxygen consumption, NIHA class of the patient, post-exercise LVOT gradient, and also improvement in the patient-related outcomes, which was measured by 2 scores, the Kansas City Cardiomyopathy Questionnaire and the Hypertrophic Cardiomyopathy Symptom Questionnaire. Regarding the results of the study, the Explorer Hypertrophic Cardiomyopathy study showed that twice as many patients achieved the primary endpoint of the clinical response in the mavastatin group versus the placebo group. Regarding the secondary endpoints, mavastatin demonstrated significant improvement in all the secondary endpoints compared to placebo. Secondary endpoints including the peak oxygen consumption, the NIHA class of the patient, the LVOT gradient, and the patient-reported outcomes by the scores we have mentioned before. What about the safety issues regarding the mavastatin? The study showed that there was no significant safety issues regarding mavastatin, as mavastatin was well tolerated, with no significant increase in the adverse events, serious adverse events, and the cardiac serious adverse events as compared to placebo. So, to sum up, mavastatin is the first drug developed to target the underlying molecular defect in hypertrophic cardiomyopathy. The Explorer Hypertrophic Cardiomyopathy study was the most comprehensive and adequately powered randomized clinical trial conducted to date in patients with hypertrophic cardiomyopathy. In the Explorer Hypertrophic Cardiomyopathy trial, treatment with mavastatin improved symptoms, exercise capacity, and key aspect of health status in patients with obstructive hypertrophic cardiomyopathy. These positive results, which we had in the Explorer Hypertrophic Cardiomyopathy trial, represent a major achievement towards improving the lives of these patients with obstructive hypertrophic cardiomyopathy and support a role for targeted medical treatment in this patient group. So, of course, this trial had paved the road for other trials searching on the and explaining and trying to improve and trying to prove the role of mavastatin. We have the Valor Hypertrophic Cardiomyopathy trial, which is an ongoing trial. The Valor Hypertrophic Cardiomyopathy trial is including the patients who were not included in the Explorer Hypertrophic Cardiomyopathy trial, who are patients with NIHA class 4. As we can remember, in the Explorer Hypertrophic Cardiomyopathy, we included only patients with class 2 and 3, and also patients who are on disopyramide, who were not included in the Explorer Hypertrophic Cardiomyopathy trial. Also, we have another ongoing trial, which is the MAVELET trial. This trial is following up the safety and the efficacy of mavastatin for a longer period, for 5 years. Thank you.
Thanks a lot, Amir, for elegantly presenting this trial. And the first 2 slides, when you were explaining how this drug worked, it jumped to my mind that this drug is working by the exact opposite mechanism of omecamtiv mecarbil, the drug which is used in heart failure.
Yes.
Yes, it's the exact opposite mechanism. One of them is a cardiac myosin activator, and one of them is a cardiac myosin inhibitor. So it looks like targeting this cardiac myosin actually is the new trend in heart failure management if the cardiac myosin is not working properly and you need to activate it, or in the hypertrophic cardiomyopathy if the cardiac myosin gives you some very powerful and obstructive situation, so you need to inhibit this activator. So maybe I can perceive this mavacincline actually something like diuretics in heart failure, which reduce the volume overload and are a cornerstone in every single patient with HFrEF or HFpEF to control the volume situation, control the quality of life, and control the symptoms. Because as we know that in hypertrophic cardiomyopathy patient, we have one of them is the obstruction because it leads to low cardiac output symptoms. It can lead to syncopal attacks, and it even can lead to significant myocardial ischemia. On the other hand, the molecular basis of hypertrophic cardiomyopathy, including the fibrosis and the infiltration of the myocardium, which end up by the arrhythmia cascade and the eventual heart failure and death. So for me, Amir, I would think that to use this medication, you need to have a patient with a good ejection fraction, because you cannot use this medication if the patient is a burnt out hook'em or if the patient has an impaired ejection fraction. And number two, I think what will be very interesting would be the long-term follow-up, because this is the 30 weeks trial and it included all the symptomatic endpoints that need to be targeted. But maybe on the long run, I would be very interested to know what happens with the ejection fraction or for using this medication for 5 years. What will be the effect on the ejection fraction, and if this drug actually will show a positive effect regarding the mortality of those patients in follow-up for 5 years. What do you think, Amir? I want your insights about this.
Oh, okay. Dr. Muhammad, you said very important and very to the point things. First of all, regarding the ejection fraction, as you exactly said, this study included, it was one of the inclusion criteria of the patient that they must have a left ventricular ejection fraction more than 55%. In order to exclude patients with left ventricular dysfunction and patients with burned out myocardium, exactly as you said. Of course, managing or inventing drugs that can improve patients with hypertrophic cardiomyopathy is a very huge dilemma. As in patients with obstructive hypertrophic cardiomyopathy, the obstruction and the symptoms are mainly due to multiple causes that combine together, including the increase in the left ventricular wall thickness and the hypercontractility, in addition to the mitral valve abnormalities and the systolic anterior motion of the mitral valve that increases the gradient. So here, regarding the mavacincline, it is targeting the, as you said, the actin myosin cross bridges, trying to decrease their presence, and so decreasing the hypercontractility of the left ventricle in these patient groups. Regarding the effect of mavacincline on the left ventricular ejection fraction, it was targeted in this study, and they reported that there was no significant reduction in the left ventricular ejection fraction with using the mavacincline compared to the placebo.
Yes. For the short term of the 30 weeks, yes, I'm
Of
sure it will
course,
not affect the ejection fraction, but maybe
of
with the
course,
5 years follow-up, we would be interested to know the data. Thank
of
you
course,
so
yes.
much, Dr. Amir. This was a very elegant presentation of two of the very important trials, starting the use of rivaroxaban in atrial fibrillation patients with bioprosthetic mitral valves, and the use of a new medication, mavacincline, which is a cardiac myosin inhibitor in a specific situation or subset of patients, which is the hypertrophic cardiomyopathy in the Explore HCM trial. Thanks a lot, Dr. Amir, for this elegant and wonderful illustration.
Thank
Thanks
you,
a
Dr.
lot,
Muhammad.
Dr. Omar Saleh, for joining us tonight. Yes, and thanks a lot, Dr. Karim
Thank you very much.
Mahmoud and Dr. Ahmed Saeed for joining us in this session. And hopefully we can meet you next Thursday, inshallah. We will have part two. Very interesting trials, very interesting updates, and very elegant speakers. And see you next week, inshallah.
Thank
Good
you.
night.
Thank you very
Thank you,
much.
Dr. Muhammad.
Thank
Thank
you.
you. Thank you. Thank you.